alternate pattern. On the short axis, you see the normal starry night appearance. Additionally, dynamically, you would see the muscle contracting and getting enlarged or smaller, depending on which way the contraction is occurring. Moving on to the volar wrist, we'll look at the carpal tunnel, Guillen's canal, the wrist and finger flexors, talk about wrist ganglions, move on down to the fingers and talk about pulleys. There'll be a section on differentiating different types of tenosynovitis injuries, flexor tendon injuries, and then again wrapping up with some anomalous muscles and potential tumors around the hand. As we know, carpal tunnel syndrome is a very common problem in the population. The carpal tunnel is composed of a bony base with an overlying retinacular structure, the transverse carpal ligament. Within the tunnel, you have 9 tendons in the nerve, the median nerve. The 9 tendons are the 4 tendons of the FDS, 4 tendons of the FDP, and the flexor pollicis longus tendon. The entrance to the carpal tunnel is the tubercle of the scaphoid and the pisiform. So here's a sonographic image. The purple line here denotes the transverse carpal ligament. Here's the median nerve here in the center. The distal extent of the tunnel is the tubercle of the trapezium and the hook of the hamate. The line, dotted green line here, is the rough location of the distal transverse carpal ligament. The distal aspect of the ligament is much thicker than it is volarly. Typically with ultrasound, we're asked to look at the carpal tunnel to see if someone has carpal tunnel syndrome. There's a variety of studies assessing this. Here are some of the common numbers that would be used when assessing for carpal tunnel syndrome. Most often we're looking at the cross-sectional area of the median nerve within the carpal tunnel, as well as different places along the forearm. In general, if the cross-sectional area of the median nerve within the carpal is greater than 9 square millimeters, they likely have carpal tunnel syndrome or median neuropathy at the wrist. Another way of looking at this is comparing the cross-sectional area of the median nerve at the proximal 1/3 of the pronator quadratus to the maximal area of thickness within the carpal tunnel. If that difference is greater than 2 square millimeters, that would also suggest the presence of median neuropathy at the wrist. Some would use ultrasound as a screening tool to determine whether or not an EMG would be necessary. Again, if the cross-sectional area of the median nerve within the carpal tunnel is less than 9, some would suggest that you do not need an EMG. If it is grossly enlarged at 17 square millimeters, then again, some would suggest that you do not need an EMG, as it is grossly apparent that they have median neuropathy at the wrist. This study at the bottom here has compared sonographic findings to that of electrodiagnostic findings, allowing us to give some degree of severity or involvement. Using the cross-sectional area of the median nerve at maximal enlargement within the carpal tunnel, if it's less than 10, they would say it was normal. If it was 10 to 12, they would categorize it as mild. 13 to 15, moderate. Greater than 15 would be categorized as severe. In addition to size, you should also look at the echotexture. So if there's increased hypoechogenicity or enlargement of the fascicles, that would also suggest injury. If there is an indentation of the nerve by the overlying thickening of the transverse carpal ligament as depicted here, that would be considered a notch sign. The notch being compression of the nerve with enlargement of the nerve proximal and distal to the transverse carpal ligament. These two images here on the left show how you would measure or do the cross-sectional area comparison between the proximal third of the pronator quadratus to that of the maximal enlargement of the nerve within the carpal tunnel. Again, if that is greater than 2 square millimeters, it would suggest the presence of carpal tunnel syndrome. Of course, there's always going to be variations in anatomy, and so you may see patients with a bifid median nerve. So here is one limb of the median nerve, and here is the second. Faintly here you can see the presence of a persistent median artery, which is a branch off the ulnar artery at the level of the elbow. This video will make the appearance of the bifid median nerve more apparent. If the patient does have a bifid median nerve, you need to separately measure the cross-sectional area of both, add them together, and that would give you the total cross-sectional area. Carpal tunnel, ultrasound-guided carpal tunnel injections can be performed. This study suggests a way to do it. Typically, the transducer would be held axial relative to the wrist. The needle would be brought in from an ulnar to radial direction in plane with the transducer. It would come in over top of the ulnar neurovascular structures and then place either deep or superficial or some combination relative to the nerve where the injectate could be placed. Again, as technology advances and operators become more skilled, we're verging on doing surgical procedures with ultrasound guidance. There's been over 600 peer-reviewed cases in the literature with no report of injuries, no need to convert to a surgical release, with similar outcomes as would be reported with open and endoscopic release. The procedure has been performed with a variety of tools, either hook knives borrowed from surgery or devices created specifically for the procedure. Here's an example of how a procedure may be performed. This device is brought in under sonographic guidance into the carpal tunnel. It's then placed along or deep to the transverse carpal ligament in an area called the transverse safe zone, which is an area between the median nerve and the hook of the hamate. Here you see the device in between those two structures. This particular device has an extra added safety feature built into it, where saline balloons would be inflated, as depicted here in this top right image. The balloons further displace the median nerve away from the center of the device where the knife is located, increasing its margin of safety. This top right image, the bottom of that image, shows the actual blade coming up through the transverse carpal ligament, creating the incision in the ligament. The patient would be left with a small incision along the distal forearm. Here are a couple of videos demonstrating that as well. Here we see the balloons being inflated, further displacing the median nerve away from the center of the device, again, where the knife is located, increasing its margin of safety. Here we see the knife being brought up through the transverse carpal ligament, dividing it, creating the release. And then lastly, we can use the device to then push up through the cut in the ligament, ensuring that the ligament has been completely released. Importantly, when doing these more advanced procedures, we need to ensure that we know all the structures that we would want to avoid, specifically the thenar motor branch. As we know, this is the motor branch that comes off typically from the radial aspect of the median nerve, and then would come back from a distal to proximal direction and enter into the thenar muscles. This video shows the thenar motor branch coming off the median nerve. Here it's a hypoechoic structure, very small, but coming off from a dorsal location, a volar location off the radial limb of the median nerve, and then moving more volarly, kind of overlapping the distal ends of the transverse carpal ligament, entering the muscle. Again, you're always going to run into surprises. So there are some variations in the thenar motor branch. Sometimes they'll come off from the ulnar side, which may make releasing it ultrasonographically more difficult or perhaps inappropriate. This video shows a thenar motor branch which is coming off proximal to the carpal tunnel. So here's the median nerve. Again, this is a high resolution ultrasound image. The thenar motor branch is coming off proximal to the carpal tunnel, then traverses through the transverse carpal ligament. Doing an ultrasound guided release in this case would likely potentially lead to injury to this nerve and therefore be inappropriate. Here, this video shows the nerve coming up through the transverse carpal ligament. Moving on to the ulnar neurovascular structures, or they live within Guillen's canal in the wrist. That canal is formed by the pisiform proximally and the hook of the hamate distally. The roof is formed by the palmar carpal ligament. The floor is the extension of the transverse carpal ligament. The ulnar artery lies radial with the ulnar nerve ulnar to that. At the entrance, it's a singular nerve or a mixed nerve where there's both motor and sensory fibers. Overlying the hook of the hamate, that mixed nerve splits into a superficial sensory and a deep motor branch. The nerve here can be subject to compression from ganglion cysts off the piezotrichoidal joint, aneurysms of the artery, or sometimes in those people that have an accessory abductor digiti minimi. Moving on to the finger flexor and wrist flexor tendons. Again, the carpal tunnel houses 9 tendons, 4 FDS and 4 FDP, with the flexor pollicis longus being most adjacent or along the scaphoid. The flexor carpi radialis overlies the scaphoid. The flexor carpi ulnaris will insert into the pisiform. This video shows how you could assess those tendons of the finger flexors excuse me, dynamically by having the patient move their fingers, allowing you to see them more clearly. This image is a long axis view of the flexor carpi radialis. This is a very challenging tendon to see all the way down distally, as it lives in its own fibroosseous tunnel created by the tubercle of the trapezium, somewhat overlapping the tendon. The tendon itself is inserting here into the base of the second metacarpal. The bottom right image shows the flexor carpi ulnaris coming down into the pisiform. The pisiform, as we know, is a sesamoid bone. The tendon then extends down to the hook of the hamate, forming the piezo-hamate ligament. There's another extension that goes from the pisiform down to the base of the fifth metacarpal, forming the piezo-metacarpal ligament. Along the volar wrist, you may also see ganglion cysts. These usually arise from the radiocarpal joint on the radial aspect of the wrist and are often either adjacent or wrapping around the radial artery, making them much more difficult or potentially inappropriate to aspirate. When I see these and they're wrapped around the radial artery, I'm usually referring them to surgery for direct decompression. Moving down to the fingers, the flexor tendons, the FDS and FDP, are held in place or adjacent to the underlying bone through retinacular structures. These are depicted here in this diagram. The odd ones overlie the joints, the even ones overlie the middle aspect of the proximal and mid phalanx, respectively. The most commonly involved ones clinically would be the A1 pulley, which would be responsible for trigger finger or thumb. The A2 through A4 pulleys can be injured traumatically through forced finger flexion, such as may be seen with rock climbing, where the retinaculums would tear and then lead to impaired function of the fingers as a result. Again, pulley ruptures would allow the tendons to migrate off the bone. Typically, the retinaculum holds the tendons down against the bone tightly. This allows for a greater degree of excursion of the joints where the tendons are acting. If the tendons are allowed to bowstring off, then the patient will not have as much of a degree of flexion at the respective joint, thereby impairing their function. This diagram shows a rupture of the A2 pulley in this case, allowing the tendons to bowstring off the underlying phalanx. This sonographic image shows that process where the tendon is elevated off the phalanx here, and there's an effusion either within the tendon sheath or between the tendon and the underlying bone. These videos show normal tendon excursion here on the left. So normally the tendons would be freely mobile underneath the retinacular structures. If they were thickened or injured, they may impair the sliding or gliding of these tendons. To assess the integrity of the tendons A2 through A4, you may also want to load the tendon isometrically, trying to push the tendon off the bone. Here you see a normal amount of motion occurring between the tendon and the bone. Here's an example of an A2 injury. The left image here shows both the right normal side and left involved side. As you see on the right side, the tendon's held immediately adjacent to the bone, whereas on the injured side, it's held up off the bone through this effusion. This video here shows that the tendon is moving away from the underlying bone, again signifying injury to the overlying pulley. In this case, it's the A2 pulley. Moving back to the A1 pulley for the finger and thumb, this can cause triggering or stenosis of that compartment or the region. It would trap the tendon between the overlying thickened retinaculum and the underlying joint. This causes pain and inability to either flex the thumb, or can cause trapping of the finger in a flexed position. Normally, this is a clinical evaluation. However, sonographically, there are some signs of this. One being thickening of the retinaculum, similar to, as I mentioned before, with Decker veins, the retinaculum being much thicker, squishing the tendon against the underlying joint or bone. Additionally, it would cause the flexion of the tendon, where you would get anisotropy of the tendon, or the dark tendon sign. Additionally, because of the thickened retinaculum, you're going to get a little bit more roundness to it, and that's going to cause a little refractile shadowing at the edge of the pulley, again contributing to some of that dark tendon sign. And then lastly, dynamically, as I showed previously, the tendon should move freely underneath the pulley. If this tendon is being squished between the pulley and the underlying bone, then that tendon excursion would be impaired. Here's another high-resolution image of a normal pulley. Typically, they're very hard to see, but with this high-resolution transducer, you can easily make out the dimensions of the retinaculum overlying the tendons here. Again, here's the normal retinaculum or A1 pulley. It's very hard to see. It's a hypoechoic, very thin structure. When it's abnormal, it would be many more times thick and very easily seen. Trigger finger can be treated with splinting or injections or release. Injections can be done with ultrasound guidance, either in plane or out of plane relative to the transducer or tendons. There's evidence to show that being relatively close to the pulley would make it more effective as opposed to being deep to the tendons. Again, as we advance with our skill and knowledge and higher end machines, we're able to do more things. So here's some pictures of the injection being performed, a little video here showing proper needle placement and then injection of the solution around it. Here's an example of trigger thumb. So the top left image shows the normal left and an abnormal right side, where the right retinaculum is much thicker than it is on the normal side, and then we're injecting it here in the bottom right image. Sorry. Moving on to flexor tendon injuries, there are essentially 5 types. It depends on the degree of proximal retraction of the tendon, as well as whether or not there is bony involvement, but these could be easily depicted on ultrasound evaluation. Moving on to the different types of tenosynovitis. This is more of an for your information kind of grouping of slides. Essentially, tenosynovitis can be broken up into inflammatory causes and what I would consider non-inflammatory causes or stenosing issues. So the tenosynovitis to me is typically an inflammatory reaction that involves the lining of the synovial sheath and or tendon. Causes could include systemic inflammatory diseases such as rheumatoid arthritis, amyloidosis, or gout, or perhaps infections. The stenosing ones are the ones we've covered already, including trigger finger, Decker veins, intersection syndrome, ECU entrapment, or injury to the FCR. These are related to entrapment of the tendon in the fibroosseous tendon, and that leads to degeneration of the tendon. Proliferative tenosynovitis, or one of the inflammatory causes, had traditionally been most commonly involved with rheumatoid arthritis. However, with the advent of the disease-modifying agents, I don't see this as much, but you may see it in patients that either cannot or choose not to use that medication. The inflammation starts in the adjacent tendon or joints and then propagates into the sheath. Because of the amount of swelling that can occur, it can lead to mobile kind of fluctuation of the fluid. So you might see some fluctuating movement as they move their fingers. It typically will involve the 4 through the 6 compartments. On the flexor side, it can cause compression of the median nerve, so giving the patient carpal tunnel symptoms, or it can cause entrapment of the tendon, such as would be seen with trigger finger. Here's a sonographic image along with its MRI correlative. On the sonographic image, you see thickening and proliferation of the synovial tissue of the tendon sheath. The MRI clearly shows increased fluid signal in all of the tendon sheaths and joints of this image. The fluid can cause direct compression of the tendon and the tendon sheath, as well as the arterial supply to the tendon, which can then lead to ischemia and rupture. As we know, the inflammatory disease process involves the joint as well, and it can lead to ligamentous or capsular injury, which then leads to malpositioning of bones, which then can lead to attritional tears of the tendons. More commonly, you'll see crystalline tendinopathies. So this is gout, pseudogout, or calcific tendinitis. Again, gout is monosodium urate crystals because of an overproduction or undersecretion of the, excretion of the urate crystal. It leads to an acutely painful, swollen, potentially red joint or region. If it's a clinical diagnosis confirmed with fluid sample or tissue sample, where you would see the negatively birefringent needle-shaped crystals, typically treated with NSAIDs, colchicine, and steroid injection. Prevention is preferred treatment, as well using medication as well as dietary changes. Pseudogout is related to calcium pyrophosphate dihydrate deposition, usually within the fibro or articular cartilage. Positively birefringent rhomboid crystals would be seen. Radiographically, you would see these as fluffy calcifications within the fibrocartilage or articular cartilage. It's treated similar as would be for arthritis if it's the joint. It could also lead to thickening of the flexor tendons in the carpal tunnel, leading to compression of the median nerve and carpal tunnel syndrome. Calcific tendinitis in the wrist typically involves the flexor carpi ulnaris tendon, more commonly in middle-aged women. It's the deposition of calcium hydroxide apatite within the tendon. They would present with an acutely painful, swollen ulnar side of the volar wrist. You may see it radiographically as well as on ultrasound. Deposition diseases are also responsible for causing enlargement of the soft tissue and pain and swelling of the tendons and tissue about the wrist. Amyloidosis, which would be seen in renal dialysis patients or patients with multiple myeloma, where you get deposition of this beta-2 microglobulin within the soft tissue. Again, it would cause swelling of the soft tissue, thereby potentially leading to carpal tunnel syndrome or trigger finger. Achronosis is an inability to metabolize tryptophan, again causing deposition of this homogenistic acid within the soft tissue and leading to a space-occupying lesion. Septic tenosynovitis typically would present to the emergency room as it would be quite painful. It's typically involving one of the tendon sheaths, which tend to be closed spaces, would involve some of normal skin flora such as Staph aureus or strep, or Pasteurella from an animal bite. The patients would be exquisitely tender to palpation. They would have a lot of pain with passive or active motion. You would see gross swelling of the involved region as well. Again, similar to the dorsal side, on the volar side, you'll have some accessory muscles, most commonly be presence of a digastric belly of the FDS, so 2 muscle bellies, with a more distal one encroaching into the carpal tunnel, which could then lead to extra stuff crammed into the carpal tunnel, compressing the median nerve and giving the patient carpal tunnel symptoms. As we mentioned before, you can have an accessory abductor digitominimi, which would overlie Guillen's canal, potentially compressing the ulnar nerve and giving you an ulnar neuropathy. Fortunately, tumors about the hand are usually benign. We'll discuss 3 of them. Giant cell tumor of the tendon sheath is essentially pigmented villonodular synovitis. It involves the flexor tendons, where you'll see this hypoechoic to anechoic swelling around the tendon. It may have increased Doppler signal and may cause inuberation of the adjacent bone. A glomus tumor is an avascular malformation along or deep to the nail bed, as well as along the volar tip of the finger. It would be exquisitely painful, and on ultrasound you would see a lot of chaotic blood flow. And then lastly, you can have lipomas. They can be either within the subcutaneous tissue or within the muscles, most commonly the thenar muscle. If it was in the subcutaneous tissue, it would be isoechoic to the adjacent fat. If it was within the muscle, it would be hyperechoic relative to the adjacent muscle. So that's the conclusion of my presentation tonight. Darcy, is there time for questions?
Yes, and I did send you a few. Let me know if you can see them.
Okay. Can you, sorry, can you remind me again where I would?
That's fine. If you click that orange arrow, you should be able to see your navigation bar and there's one for questions. And then you can open it up. We have at least 3.
So the first question is, do I use sterile gel for the procedures? I do, as I bring the needle through the gel on occasion. Even if I'm not doing it, I still use sterile gel. So it comes, we buy it in a kit. It comes with a cover as well as the sterile gel, and then I don't have to worry about it. The second question is, how do you load or stress a pulley of the finger? So it's usually an isometric contraction of the involved digit. So the transducer would be overlying the pulley that I'm trying to assess. And then I would have, using my opposite hand, or perhaps even the transducer, resist the flexion of the patient's finger. And then that would tension the tendon and allow either for visualization of normal excursion or stressing of the pulley, and you'd be looking to see if it would migrate away from the underlying bone. The next question is, what is the plan of examination of compartment 1? So if I understand your question correctly, the compartment 1 is housing the abductor pollicis longus and extensor pollicis brevis. Typically, I would find my Lister's tubercle and then translate the transducer still in the axial plane relative to the forearm, but migrate in a radial direction until I'm overlying the first compartment. And then I would migrate the transducer proximally and distally along that compartment. I always look at these in their short axis or cross section first. If I see an abnormality, then I'll interrogate it in its long axis as well. Next question is, do I have images for flexor tenosynovitis? All the images that I have shown in the presentation. I could keep this as a reminder, and if I find some, I can send them along to you. Last one is recap of the tumors, please. Sounds like maybe I went through that too quickly. So there's 3 types of masses that you may see in the hand. First one being a giant cell tumor of the tendon sheath. That is also known as pigmented villonodular synovitis of the tendon sheath. It's usually on the flexor side, typically in the finger region, and you would see fullness of the sheath would be anechoic to hypoechoic. There may be increased Doppler signal, and then usually it's a chronic indolent process until it becomes painful and enlarged, and it's brought to the patient's attention, and so therefore it's compressing on the adjacent bone and can cause irregularity of the bone. The next one would be a lipoma, and that is either within the subcutaneous tissue or within the muscle. If it's within the subcutaneous tissue, it would be isoechoic or similar appearance to the adjacent fat. If it's within the muscle, it would be hyperechoic relative to the muscle itself. And then the last one is the glomus tumor, which is an avascular malformation that's found at the tip of the finger. They would present with a painful swollen fingertip. The AVM is either found underneath the nail in the nail bed or along the volar tip of the finger.
Oh.
Is that all the questions?
Do you have time for a few more?
Sure.
Okay, then I'll let's get you another one.
So which direction do you ultrasound when evaluating for a possible glomus tumor? I showed mostly one projection for evaluating structures, as some structures are more amenable to interrogating or looking at them in their short axis. Some are more easily seen in their long axis. So you would look at it in both axes. To me, the nail bed would be most easily seen and or make most sense to me if it was initially interrogated in its long axis. I would then, if saw an abnormality, would also image it in its short axis or cross section.
And I've sent you just a few more, but you let me know.
Yeah, so the next one has to do, how do you differentiate PVNS versus tenosynovitis? It's a combination of history as well as physical exam and then imaging findings. And so tenosynovitis, a true inflammatory disease process outside of there being an infection, which may be isolated to a singular tendon sheath. The other ones, like rheumatoid arthritis or other systemic inflammatory disease processes, it should be more systemic. So it should be more than one tendon sheath involved. The cortical irregularities seen with the PVNS denote the length of time it's been present. And so typically with a inflammatory tenosynovitis, the patient probably isn't going to wait long enough to allow the bone to be involved from the tenosynovial involvement. Next question: what's your ultrasound injection technique for scapholunate OA? Transducer plane, needle size, gauge, etc. So that was one of my first couple slides there where I was talking about the dorsal recess. Typically, I would approach the either the radiocarpal joint or the midcarpal joint in plane with the transducer and along the long axis of the hand. So I would align the transducer with my target joint, traditionally directly underneath the transducer, and then I would find a window where I could put the needle in that region without going through a tendon, preferably, and then down into the whichever recess I'm targeting. The gauge of the needle depends on what I'm trying to achieve. So if I'm just doing an injection of cortisone or something else, I would traditionally use a 27 gauge 1.25" needle. If I'm going to aspirate it, then of course I would anesthetize first, and then I would use an 18 gauge 1.5" needle.
And then we have one last.
One last one. Do you see a difference in outcomes for carpal tunnel intervention between standard surgery versus ultrasound guided surgery? Right. So there's a number of studies looking at outcome measures. Traditionally, the Boston Carpal Tunnel Questionnaire as well as the Quick Dash surveys have been used when looking at the ultrasound guided release procedures, as those are typically the same outcome measures that would be used in either the open or endoscopic release. And as far as I understand from the review of the literature and having done a study on myself, the outcomes are comparable. The outcomes also show that the recovery from the procedure is faster, and patients seem to prefer it over the open or endoscopic release when they've had both procedures performed. So let's say they had open or endoscopic on the right, they underwent carpal tunnel on the left. They have equally good outcomes and are more pleased with their whole process with the ultrasound guided release.
Great. Thank you so much, Dr. Henning. And on behalf of the AIUM and the AMSSM, our thanks to all of you who participated in tonight's webinar. Please complete the activity evaluation and remember to visit the CME Center on our website for the post-test. We hope you enjoyed this presentation and will join us again for future webinars. Good night, everyone.